Well, good afternoon, everyone, and welcome to the Advances in Child Maltreatment Prevention lecture. Before we begin, I want to go over a few housekeeping notes. If you wish to receive CEs for today's webinar, you will need to stay for the duration of the event and respond to all poll questions you see pop up throughout the presentation. You will see the first poll question momentarily. If you do not see the polls pop up throughout the presentation, the questions will be in the chat, and please place your responses to the questions in the chat. There will be time for Q&A at the end of the event, so please submit any questions you have in the Q&A box or in the chat. We encourage participation in the chat throughout today's presentation. We're going to wait a few more moments before we get started, so sit tight and remember to respond to the polls when you see them.
Good afternoon, everyone. Happy Social Work Month. I am Beth Angel, Dean of the School of Social Work, and I'm honored to welcome you to the Advances in Child Maltreatment Prevention Speaker Series. This series was created by Professor Todd Herrenkohl, the Marion Elizabeth Blue Professor of Children and Families here in the school, and it features the work of leading prevention and child welfare scholars engaged in efforts to strengthen and reform child-serving systems. This speaker series provides a forum for new and emerging knowledge from the social sciences and the helping professions that can improve the health and well-being of vulnerable children and their families. I'd now like to introduce the creator of this series and today's moderator, Todd Herrenkohl. Todd's primary research interests focus on the areas of child and family well-being, child maltreatment, and the psychosocial and developmental underpinnings of health risk behaviors in youth and adults, substance abuse, mental and physical health outcomes of adversity, and resilience. He has also worked to raise awareness of the causes and consequences of violence in children and families, and to promote the use of public health models of primary prevention and trauma-informed care. So with that, I will turn things over to the capable hands of Todd Herrenkohl, and again, welcome and enjoy the session today.
Great, thanks so much, Dean Angel, for that introduction. And it's now my pleasure to introduce our featured speaker for today, Professor Tracie Afifi. Dr. Afifi is a Tier 1 Canada Research Chair in Childhood Adversity and Resilience and a professor in the Departments of Community Health Sciences and Psychiatry at the University of Manitoba in Canada. Professor Afifi's primary research interests are in the areas of child maltreatment and mental health, with a focus on resilience, intervention, and prevention. She is director of the Childhood Adversity and Resilience Research Team at the University of Manitoba, where her team includes distinguished researchers, students, and others with shared interests in child maltreatment and mental and physical health. Tracie is an associate editor for Child Abuse and Neglect, one of the leading journals in our field, and she has published extensively, more than 200 peer-reviewed scholarly articles, and she has presented her work broadly at national and international conferences. So it is truly a pleasure to have Tracie with us here today. And I'll just say before Tracie joins us that we will have a Q&A session at the end of the time today. So please begin to type your questions in the chat, and we will do our best to cover as many as we can at the end of the session. So without further ado, over to Dr. Afifi. Thank you so much, Tracie.
Great, thank you. So I will share my slides. And just before I begin, I just want to confirm that my slides are visible. Yes? Great. Okay, thank you so much for the lovely introduction, and also for the invitation to come together today to talk about this really important topic. I really do appreciate the opportunity to spend this time with you. So I'll be talking a little bit about resilience as a foundation for prevention of mental health and substance use problems in children and youth. And before I begin, I just would like to acknowledge that I do live, work, and learn in Canada, and specifically in Manitoba. And the campuses here at the University of Manitoba are located on Treaty 1 territory, which is the lands of the Anishinaabe, Cree, Ojibwe, Dakota, Dene, and the homeland of the Red River Métis. I'm going to be presenting a lot of work from our lab over a number of years. And so I just wanted to acknowledge the funders for the projects that I'll be presenting today. And also the collaborators as well. There's a number of collaborators who have been involved with these projects. So I wanted to acknowledge all the people that have worked on the research that I'll be talking about today. I have provided a list of recommended readings so that it has been provided to you. And if not, they're also listed here in the slides. So for the next 45 minutes or so, we'll cover these 5 objectives. So we'll start with reviewing terms in the field. And for many of you, this is likely known or review, or some of you may not have thought about too much of this specific language, but I feel like it's always really important to talk about language when we're talking about research studies, so that when we talk about different studies, we have an understanding of what's included in that work. Then we'll review the size and scope of the public health problem of child maltreatment, both at a global level and also some data from Canada. We'll talk about defining resilience and protective factors, and then I will review some of the work specifically from our lab that looks at protective factors and better mental health and substance outcomes following child maltreatment. And then from there, I think it's always important to think about child maltreatment from a prevention standpoint and also from a public health perspective. So we'll talk a little bit about prevention from a public health perspective. So here's the first poll question. Can the terms child abuse, child maltreatment, adverse childhood experiences, and childhood adversity be used interchangeably? Yes or no? So I'll pause for a moment and let you respond to the poll question. Okay, so thank you for that. Very interesting results here. So we have about 24% of those who voted saying yes, they can be used interchangeably, and 76% saying no, they cannot be used interchangeably. So the answer to that is just move the poll down here. There we go. The answer to that is actually no, they're not interchangeably used terms in the field. So all of these terms here sometimes do get used interchangeably, and I think that's what's really important to have the conversation, to understand that actually all the terms listed on this slide do represent different aspects of violence within childhood. So we're just going to briefly go through what the distinction is and the overlap of some of these terms. So when we're talking about child abuse, we're talking about physical abuse, sexual abuse, emotional abuse, and exposure to intimate partner violence. So most of the child abuse definitions include these types of abuse. But notice that neglect isn't included in these definitions. So if we're talking about neglect, then it might be physical neglect, it might be emotional neglect, but neglect is not included if we're using the term child abuse. But if we're using the term child maltreatment, then that actually includes the types of abuse as indicated, and also the 2 types of neglect that's included there. So if you're talking about abuse and neglect together, then the most appropriate term to use would be child maltreatment.
Tracie, I'm sorry to interrupt. Your slides are showing in the presenter view,
Oh.
so you want to.
Okay, sorry. I don't. Let's see here how to fix it. Were they always in the presenter view, or is it just since the poll?
No, I think that they've been this way.
Okay, let me just end the show and I'll just move this bar down so I can see. How's that?
There you go. Perfect.
Okay, great. Sorry. Thanks. I couldn't see it at my end. So thanks for letting me know. Okay. So the term adverse childhood experiences is also a term that you're going to hear a lot in the field. And so again, the complication with this is adverse childhood experiences does include abuse and neglect. And so these are the original 10 that resulted from Felitti et al.'s original publication in 1998. So there were 10 adverse childhood experiences that were included in that study. Now, this could be a whole course just talking about the term ACEs and adverse childhood experiences. So we'll only briefly touch upon it. But for this publication by Felitti in 1998, these were the 10 experiences that they included, and they termed it adverse childhood experiences, or ACEs, and divided it into really 2 categories. So the first category is in green, which includes abuse and neglect. And the second category was in blue, which was what they originally called household dysfunction, and then turned to, now more commonly, they use the term household challenges. These data are now housed at CDC, and as you know, CDC in the United States does a lot of work in this area for the past several decades. So these were 10 that were included based on clinical experience and impression that they had. That wasn't ever meant to be an exhaustive list of all possible adverse childhood experiences. They divided them basically into 2 categories, but it wasn't based on any empirical evidence. It was sort of just conceptually, this is what made sense to them. But you'll note that mother treated violently here is in the household dysfunction category. And whereas I originally told you just a few slides ago that the mother treated violently would be considered in the abuse category. So you can see that there is differences in how we apply these concepts. Then there's been, since over the last 20 years or more since that first publication, there's been recommendations that we should expand the list of ACEs. And again, we won't get into a lot of detail with that, but it's never meant to be an exhaustive list. And the question may be, if I asked you what else are adverse childhood experiences, we could probably come up with a list of 100 different types of experiences that would be considered adverse experiences in childhood, depending on where you live, looking at different parts of the world, the list would also change. So I don't think it's a useful task to try to come up with the longest list possible. It's not practical for research. It's not practical for policy or clinical practice, but there has been some recommendation that this list of 10, which was, originally selected based on clinical impressions and experience, is not quite comprehensive. So these are some that have been suggested that might also be adverse experiences. And the ones that are here in green are the ones that indicate that there has been some empirical work done to show that they may be similar to the original list of 10. We also did some work in our lab looking at this using a large community sample of both parents and adolescents from Manitoba, Canada. And what we wanted to do is to empirically test whether or not the original ACEs all fit together in a confirmatory factor analysis, whether or not we should expand the list, and whether or not these 2 constructs that were sort of conceptually but not empirically tested from the original Felitti study, if they would hold true. So what we found, I'll just point out that parental separation and divorce, which is one of the original ACEs, was one of the ones where a lot of people said, well, I don't really think that should be considered an ACE anymore because it is quite common in North America, especially. However, empirically, it did still fit with everything, so we concluded that it would remain. And the other list in green, spanking, peer victimization, poverty, foster care placement, unsafe neighborhoods, and household problem gambling also empirically fit. We did get 2 constructs, so similar to the original data, but what happened was when we included peer victimization, which is bullying, that also it loaded with child maltreatment. So you kind of have the first construct where it's something that's happening specifically to the individual, the child maltreatment or the bullying. And the second construct is more within the household. So empirically and theoretically, the constructs made sense. And then the final term that I'll talk about is childhood adversity. So this is the broadest term. And so when I'm talking about adversity from a very broad perspective, which could include many things, I use the term childhood adversity. So it's, in my mind, it's the most broad term. And then the last point there, it says others. So in my mind, it's an open, we can add more experiences to this as time goes on and as the world changes. So it allows us to be very broad in our thinking. So like I said, it's the broadest term, and it can include things like child abuse, neglect, child maltreatment, ACEs, and things like toxic stress. So that's when I use the term childhood adversity, and I try to use the language consistently. And when I'm talking about other studies in the field, I like to try to stick with the language that is consistent with the constructs that are measured in that study. So let's expand to understanding the size and scope of child maltreatment. So here's our second poll question. Globally, how many children ages 2 to 17 have experienced physical, sexual, emotional abuse or neglect in the past year? Okay, great. So we have the majority, many people, 34% saying 10 million, 32% saying 100 million, 6% saying 1 billion, and fewer for 1 million and 5 million. There are the results there. I will just close that. There you go. And the answer is actually 1 billion children, according to data published in pediatrics. Globally, it's estimated that up to 1 billion children ages 2 to 17 years have experienced physical, sexual, emotional violence or neglect in the past year. So that actually puts it at about 50% of children who have experienced that. And again, the data from this work shows not over their lifetime, but actually in the past year. So when you go to the prevalent studies of child maltreatment worldwide, and this was across the globe using a series of meta-analyses, the range is anywhere from 4, which is much lower, to 55% of children. So it depends on what part of the world we're looking at. And of course, these studies had a lot of different measures, but we can see that there is a wide range depending on our methods and the way the world, what part of the world we're looking at. But more in some parts of the world, 1 in 2 or more than 50% of children will have experienced child maltreatment. I'll just present a little bit of data from Canada. So this is a paper that I published in the Canadian Medical Association Journal in 2014. This was actually the first nationally representative study on child abuse that was published in Canada. And of course, that might be surprising to some because the data were collected in 2012. So that was the first time that we actually had nationally representative child abuse data. So we're in Canada, we're a little bit behind in collecting some of these data. We've improved in the last 10 years, but a little bit behind in understanding these experiences at the national level. Now, this this study only, it's labeled child abuse, so we only had physical abuse, sexual abuse, and exposure to intimate partner violence available in the data set. And what we found was that in Canada, 32% of the adult population had experienced one or more of these types of child abuse. And when we looked at them individually, it was 26% had experienced physical abuse, 10% sexual abuse, and almost 8% reported exposure to intimate partner violence. So now let's shift to talking about resilience in the context of child maltreatment. So here's a very brief historical timeline of thinking about resilience and protective factors in the literature. So prior to 2000, the largest focus in this area was really more on risk factors related to child maltreatment and negative outcomes. And then in 2000 to 2009, the research shifted towards looking at strengths or protective factors and started really focusing on these concepts and definitions of resilience, which has actually changed quite a bit over time. And then from the 2010 to present day, researchers and clinicians and others in the field began to be interested in sort of more specific questions in this area. So asking questions about trying to understand why some children do well despite adversity. What are the key factors that can foster or promote resilience, and what protective factors are related to better health outcomes? So our next poll question, is resilience static? Or in other words, does it not change? Okay, I'll just give you a moment to. Okay, so we have 96% said no, and 4% said that yes, it's static. So the answer, oops. The answer is actually no, it's not static, and that resilience may vary over time, and it may vary across different developmental phases. So you may be more or less resilient as in younger age and become more or less resilient as you get older, or vice versa. So an individual's resilient status can change from resilient to non-resilient and vice versa, although it's not, just a binary concept or idea. And risk and protective factors related to resilience may also change over time. So that sort of can indicate why we think that resilience may change. So here's a figure from a publication from Helen Herman from the Canadian Journal of Psychiatry. And this is her conceptualization of why resilience can change and what factors can contribute to your status of resilience. So along the top, we have risk factors or stressors that may be in your life. And at the same time, an individual may have protective factors. So most people don't have only protective factors or only risk factors, but we have a combination of both. And they may vary and change over time. So here's some examples that were provided. These risk and protective factors sort of press on this homeostasis of resilience. So if you have a good balance, you might be able to maintain a very steady state of resilience over time. If the protective factors lessen and the risk factors increase, you may then lose this state of resilience and become less resilient, which may result in negative consequences or mental health problems. But likewise, you may also experience these traumatic events, and with protective factors may still be able to develop some post-traumatic growth, or you may still thrive despite these experiences. So this is sort of a good sort of understanding of how these elements work together over time to change one's ability to move in and out of a resilient state. So early in the field, resilience definitions focused on individual characteristics that were static or innate or unique or special to that child. And this definition was later considered to be quite limiting because it kind of suggested that a person is just born being either a resilient person or not a resilient person. So it was just sort of an innate quality that someone had or did not have. And then with more research and understanding and thinking about the concept of resilience, this sort of expanded to a multi-level definition. So a person might have some innate individual characteristics that they are born with, and that can be referred to as assets. As well as there can be some external factors to the individuals, and some people have referred to these as resources. So you can have both assets and resources that have an play in whether or not one person is resilient. So this is sort of more the present day thinking of resilience. So it's a combination of these assets or innate qualities, and then the resources, which are external. So some of these assets might be genetics, other innate characteristics, parts of personality that are thought to be hereditary. Resources or elements within a person's environment or social systems, and it's thinking about that within individual level. It could be within a family, a school, a workplace, community, culture, society. And that resilience is a dynamic interaction between these assets and resources that enables a person to become resilient over time. So resilience among maltreated children is present when children show a normal range of competence across several domains of functioning. So the developmental domains of functioning could include behavioral competence, emotional competence, social competence, and academic achievement. Now, I think this is important because in the past, and this also is in keeping with definitions of mental health or well-being from the WHO. In the past, we thought of, a good status or resilient or being having good well-being as the absence of bad things. So if you didn't have a mental disorder, then you were, everything was good. But we've expanded the way we think of that and our idea of thinking that it can't just be the absence of bad things, but it should also be the presence of good things. And also that it can't just be, for example, in the early resilience papers, the outcome might have been depression, yes or no. So if you didn't have a diagnosis of depression, then you were considered resilient. And we know that that's quite limiting. So really, when we think of resilience, we want to think of being competent across a range of functional categories. And although we know that childhood adversity is associated with increased odds of poor outcomes, we've also noticed that some children do not experience the negative outcomes and they appear to be more resilient. And it's really that first bullet point that made me interested in focusing a lot of my work in this area, because it wasn't that every child would experience the negative outcome. So I started to be very curious about the individuals that didn't experience the negative outcome and tried to understand, well, if they've experienced similar things, and some maybe even experienced worse child maltreatment, why is there a difference in the outcomes there? So it may be that despite experiencing adversity, these individuals have certain protective factors that might help them to overcome the risk. And that may be related to their better outcomes in childhood and adolescence, and over time across the lifespan. I also want to point out to Ferguson Zimmerman's protective resilience models. There's a lot of really good work that they have published, and they theorize that the protective factors may moderate or reduce the negative impact of risk and adversity on an outcome. So, for example, some individuals may experience child maltreatment, but still maintain or develop protective factors, which reduce poor outcomes. And protective factors may also influence how a person responds to the adversity or the child maltreatment, and it may moderate or lessen the negative outcome following adversity. So here's our next poll question. Protective factors can be found at what level? Okay. So looks like people have responded there, so I will end the poll. Okay, so the answer is actually all of the above. They can be found on all of the levels listed there. So resilience following child maltreatment. We did a review, Dr. Harriet McMillan from McMaster University in Ontario, Canada, and I, a number of years ago now, did a review of the literature looking at the protective factors following child maltreatment. And what we found from the literature at the time, so this was published in 2011. So at the time, the review indicated that resilience following child maltreatment was mostly found, the most robust and common findings that we found were at the family level. So if you had a stable family environment, or if you reported supportive relationships within the family, then that was most robustly associated with the increased likelihood of resilience following child maltreatment. The most common or robust individual level protective factor across those studies at the time was a personality trait called locus of control. So it was whether or not an individual felt that they were in control of their future. So if they felt like they had control of their future and they could determine their destiny or their path forward, then those individuals did better. And if someone felt more that they couldn't control that, or they felt a little bit more helpless, then that was considered to be less not be associated with that. There was very few community level factors that were even included. So we couldn't even come up with any consistent community level factors. There was no societal level factors. There was no within community individuals looking at school level factors. That also wasn't part of what was really in the studies at that time. And so now, many of you probably see this, and this is of course developed out of Bronfenbrenner's work with the individual in the middle, and being within a family, within a school, within a community, within a society. And so what we know is protective factors can be found at all of these levels. So it could be at the individual level in terms of being optimistic about the future or having cultural connections. It could be at the family level as a supportive parent, at the school level, having a trusted adult in the school. Community could be being within your community, and then also at the societal level as well. But importantly, even to date, there's fewer community and almost no studies that look at societal level factors, which, as you can imagine, are harder to measure in research. So I'm going to focus now on some of the studies that we've done in our lab that have looked at resilience following child maltreatment. So this was one of the first studies that we conducted in 2016, and this is using Canadian data. And we're interested in looking at the individual and relationship level factors related to better mental health outcomes following child abuse. So this was data from the Canadian Community Health Survey. So it was collected in 2012. So it was nationally representative of the country at the provincial level. And it was a large sample size, so over 20,000 individuals. The child abuse questions were only asked of those who are 18 years and older. So this study was restricted to those who were 18 years and older with retrospective reports of child abuse. So again, this data only included physical abuse, sexual abuse, and exposure to intimate partner violence. Now, we wanted to take the concepts that we've talked about in terms of resilience. So we didn't want resilience to be just one dimension. We didn't want it to be the absence of a mental disorder, or specifically just one disorder such as depression. We wanted it to be more broad than that and encompass more areas of function. So we included mental disorders, a large number of them, but also suicidal ideation. So if you had thought about suicide in the last year, but then we also included indicators of psychological well-being and functioning. So this is how we conceptualized what we thought of as being resulting in better mental health outcomes, or what the concept driven by what we were considering resilient. So in that green box, it says good mental health. So in order to be considered having good mental health, you had to have no past year mental disorders and not have thought about suicide in the last year. But in addition to that, using the Corey Keyes measure of psychological well-being and functioning, you had to be in the flourishing category. Then we had moderate mental health. So that would be if you had no mental disorders and no past year suicide, but your well-being and functioning was moderate, or you had mental disorders, moderate functioning and well-being, but no suicidal ideation. Then the rest of the bars there, in red, were how we indicated for mental health. So in our overall sample, we had of the prevalence of good mental health, including that, all three of those constructs. 67% of our sample had good mental health. 28% had moderate mental health functioning, mental health functioning, and 4% had overall poor mental health in the sample. So here's our fifth poll question. What would you think the prevalence of good overall mental health would be among those who had a child abuse history? So you can recall in the whole sample, it was 67%. So how many do you anticipate would have good overall mental health in those three categories if they had experienced child abuse? I'll just give you a few seconds as I see people are still answering. Okay, looks like everyone has answered now. So we have quite split actually for the first three categories. So I'll share the results there. So 36% say 19, 34 say 37, 26 say 56, and 3% say 79. So I'll stop sharing. There's that. So the answer is actually, so those without mental health, those without a child abuse history, the overall mental health went up to 72, so from 67 to 72. And if you had a child abuse history, the overall mental health went down to 56. So you can see that it does go down compared to the overall sample, which would be expected. So the answer was 56. But again, the question remains important that 56% of those with a child abuse history are still reporting really good mental health in terms of having no disorders in the past year, not thinking about suicide in the past year, and having flourishing psychological well-being and functioning. So 56% are still reporting good in all those categories. So what we wanted to know then, what protective factors are associated with these better outcomes in that group? So from this study, at the individual level, we found that higher education and income was associated with an increased likelihood that they would be in this better mental health category, moderate to vigorous physical activity, and good coping skills. And from a relationship level factors, it was supportive relationship factors that specifically fostered attachment, that provided guidance, that had reliable alliance, that made you feel integrated socially into a group, and that had reassurance of worth. So those were the specific constructs of those supportive relationships that were found to be associated with better mental health following child abuse. And then also in the study, we also found that if you stayed in school longer, had a higher income, so those two are likely related, being married or common law, not having a physical health condition, being physically active, and the ability to handle unexpected problems in the day-to-day, and having good relationships with family and friends were also related to better outcomes. We also looked at individual level factors specifically among adolescents, and this data set was from the United States. So this is looking at the National Comorbidity Survey of Adolescents. So it's a nationally representative survey from the United States of individuals who were aged 13 to 17, and there was about 10,000 in our sample. This study, we were able to look at child maltreatment. So again, we're looking at abuse and neglect. So we were able to look at physical abuse, emotional abuse, sexual abuse, physical neglect, and exposure to intimate partner violence. We tried to measure our construct of better mental health or resilience in a similar way, but of course, these are both secondary data analyses. So we weren't able to look at it exactly the same way, but the constructs or the conceptualization was the same. So we had, again, a mental disorder in the past year, yes or no, and suicidal ideation, yes or no. We didn't have the Keys measure of well-being and functioning, but instead we used a question asking about their perceived mental health for the last 30 days. So only those who said it was excellent or very good, along with no mental disorders and no past year suicidal ideation were categorized in the best category of good overall mental health. And then you can see our moderate and our poor mental health categories. So in this sample, using these definitions, those with overall mental health in the good category was 41%. Moderate was 47%, and poor was 11%. And then we wanted to look at what were the protective factors that were associated with better mental health outcomes in this sample of adolescents from the United States. So physical activity, again, and that at the level of several times a week was associated with these better overall mental health outcomes. And positive coping skills, which is similar to our other study as well. So more specifically, what type of skills? It was the ability to keep calm, the ability to analyze and solve a problem, ability to seek advice from others, and the ability to make a plan of action and follow it. Positive self-esteem was also related to better health outcomes, and life determined by own actions, making plans, and hard work. So that's sort of in keeping with the construct of locus of control that we did find in a lot of our earliest studies in this area. We used the same data set in another publication specifically looking at relationships and community level factors. So again, this is the same data set from the United States of adolescents. And what we found was emotionally close relationships with mother and or father, good communication with mother and or father understands problems and worries, and family members feel close. All of these constructs within the family were associated with better overall mental health outcomes for adolescents. Importantly, there were very few to no findings that were associated with resilience among sibling relationships, and very few with friends. There was only one that was associated with friends, and that can open up to friends. But talking to friends about problems, which is or worries, and relying on friends to help solve serious problems, those were not statistically related. At the school level, we did find several protective factors. So teachers treat them fairly as perceived by the adolescent. That they care about what the teachers think of them, that they like school, getting good grades in school is important, that they like their teachers, and that they try hard at school. All of these school-related constructs were related to better mental health among adolescents with a child maltreatment history. And at the neighborhood level, we found being happy living in your neighborhood was a protective factor among these adolescents. So even though we have these large data sets that are nationally representative, either from Canada or the United States, we found that they were limited in terms of the scope of protective factors that were included. So what that led us to was wanting to do our own primary data collection among adolescents and a parent in Manitoba. So this is called the Wellbeing and Experience Study, so the WE study. So this was data that we collected starting in 2017, and we collected it every year for 5 years. And we did 5 cycles of data for the adolescents and 2 cycles of data for the parent. So we wanted to focus on their experiences, positive and negative, and and include protective factors that we were wanting to look at in the other studies but weren't available. So this the first study I'm going to show you is just using baseline data collected from 2017 and 2018 from Manitoba, Canada. It's a community sample, but it includes urban and rural neighborhoods. Adolescents were set 14 to 17-year-olds old at the time, and we had 1,000 adolescents paired with 1,000 of their parents. In this study, and I'll just go through this briefly, we were looking at substance use problems, so cigarettes, alcohol, and cannabis, and we had all of these adverse childhood experiences that we had included in the study. So this is just prevalence, just of interest of among their sample of cigarette use, alcohol use, and cannabis use, both past year, past 30 days, and in a typical month that we measured in this adolescent sample. And this is the prevalence of adverse childhood experiences in this sample. I'll just pause there because there's lots of numbers and different types of adversities on that page. So the findings were that all individual ACEs were associated with increased odds of substance use. There's no interaction effects between ACEs and peer victimization on substance use, but there were several cumulative effects for ACEs and peer victimization and among substance use. So this slide just shows that cumulative effects. So if you had ACEs without peer victimization, you can see the odds ratios there of experiencing the different types of substance use outcomes. You also have peer victimization without ACEs. And then if we had both the ACEs and the peer victimization together, you can see that there's a stepwise increase there. So having both the ACEs plus experiencing peer bullying or peer victimization was had larger effects for for substance use compared to having one of those experiences alone. So with that data, then we want to we're looking at adverse childhood experiences. What we wanted to do then is to understand what are the protective factors that might decrease the likelihood of nicotine, alcohol, and cannabis use among the sample who have had experiences of adverse childhood experiences. So this is, again, broader than looking at child maltreatment only. So we wanted to look at individual, family, school, and community level factors that are protective at reducing past 30-day substance use. So again, this is the same data that we just looked at for the substance use. And so what were the protective factors that we found? So here is a table summarizing all of the factors that we found that were related to decreased likelihood of substance use for this adolescent sample. So at the individual level, identifying with culture or language, becoming excited about the future, and visualizing one's future was all associated with decreased odds that they would use any of those substances, nicotine, alcohol, or cannabis. At the family level, a trusted adult in the family, being hugged by a parent or guardian, being told, "I love you," by a parent or guardian, eating regular meals with at least one adult family member, having supportive relationships with a mother or mother figure, and supportive relationships with a father or father figure. At the school level, supportive relationships with a peer at school were protective, trusted adult at school, and feeling like you belonged at school. And at the community level, a trusted adult in the community, volunteering in the community, feeling involved in the community, and feeling motivated to help and or improve one's community were all associated with decreased odds of substance use in this adolescent sample. So quickly then, a summary across all studies that we conducted. Individual level protective factors were consistently important in reducing poor mental health and substance use outcomes. Family level, especially the parents and caregivers, were really important. There was a lot of school level protective factors, which could be promising for school level interventions. And we've noted that more research does need to be done at the community and the societal level in our work and across the field. Siblings and friends in our studies did not show as robust findings for protective factors compared to adults in those children's lives. And this is just a summary. I won't read this out, but sort of putting it all together from all the studies that we've done at the individual level, at the family level, and at the school level of factors that were considered to be protective. And if you look at the literature, so beyond the work that we've done, there's been other reviews that have been conducted. There are 3 here that I'm highlighting, and they've also looked at individual, family, school, and community and societal level. Again, I won't read out this slide, but you can see that some of these protective factors are ones that we have included in our work, and some are actually are unique and not ones that we've included in our work as well. So looking at the larger literature, there's quite a few protective factors that might show promise for reducing negative outcomes following child maltreatment. Now, I know we're getting close to the end of our time, so I think that it's really important to think about what protective factors reduce the likelihood of poor outcomes following child maltreatment. But I also think it's really important to think of child maltreatment from a public health perspective and to try to make sure that we are never losing sight of the fact that the most important thing that we need to do is try to prevent the child maltreatment from occurring in the first place. So thinking about child maltreatment from a public health perspective. So public health on its own is the science and art of preventing disease, prolonging life, promoting health, and through the organized efforts of informed choices of society, organizations, and public and private communities and individuals. So we know that child maltreatment is a major public health problem, and we know that it's related to child mortality and morbidity, and it can have lasting effects across the lifespan. We know that neglect can be just as damaging as physical abuse or sexual abuse, and that there's a high burden and serious long-term consequences once the child maltreatment has occurred. So some of our research is indicating what we can do to intervene and to lessen the effects after the child abuse occurs. But I think it's also really important to try to, at the same time, we can't lose sight of the prevention aspects from a public health approach. So in order to do that, we need to be detecting the problem, identifying what's causing the problem, identifying and developing and implementing evaluation programs so that we know that they're effective, and assessing that impact of the intervention so that we know that what we're doing actually has a positive benefit. So a public health approach to child maltreatment starts with information about the prevalence and risk factors. This is followed by developing and testing interventions. So some of the protective factors that we've identified in our work, the plan will be to develop those into intervention strategies and test to see if those actually can reduce in an intervention perspective those negative outcomes, and could be developed into something that could be modifiable for individuals in terms of developing protective factors or developing resilience. And we want to make sure that the prevention of future problems by addressing these high risk circumstances. From a public health perspective, and I know this is something that the United States does a lot better than we do in Canada, but surveillance is a very important concept in terms of public health. So we have to understand the size and scope of the problem, and importantly, develop and understand trends over time. So we have some infrastructure and some mechanisms in place to look at this over time. The Public Health Agency of Canada does the most of our surveillance work in this area, but it's something that requires longitudinal surveys. So a 4-step public health approach would be to include surveillance, to make sure you're doing research to continually identify risk and protective factors because they do change over time. We want to include the development and evaluation of interventions, and then we need broad dissemination, evaluation, and continual assessment to ensure that all the components of our strategy fit with community context and have the desired effects for preventing violence. And so in a Canadian perspective, these are our recommendations. We need national surveys that include all 5 types of child maltreatment. We need to fully understand the negative consequences of child maltreatment. We need to develop more specific protocols to ethically and safely collect the data, because we can do this in safe ways, but sometimes people are hesitant to collect data in this area. We need to understand risk and protective factors. We need longitudinal data. Family violence needs to be included in our administrative data sets. Currently, we don't have good measures of family violence in administrative data sets, and systematic changes to child welfare and more universal supports for families with a focus on primary prevention and adequate resources. So this is just a proposed surveillance and research framework for child maltreatment that we've included, and it mentions all the aspects that we've just talked about, including surveillance and protective factors at all the various levels. So we can also look at policies and strategies that are in place at the global level. So the WHO is a place where they've developed a lot of strategies that are evidence-based and informed. But in Canada, we are also trying to have things like child allowances, tax reductions, guaranteed income supplements, which are promising public health tools. So here's just a few examples of places you can go to look at prevention strategies and some of the WHO publications that are available. I'll just skip over this quickly, but we want to make sure that we have ongoing data collection, and that prevention of child maltreatment requires that we're coordinating across sectors so that we're implementing the measures at the policy and community levels, and that we're making sure that we have effective interventions for families. We can't just develop interventions and assume they work. We have to have evidence that they're effective. So our upstream approach is to we have to recognize that we have a public health problem with child maltreatment, but we also need to make sure that we're addressing policies and strategies for prevention. We need to invest in these upstream prevention approaches, and our greatest gains will be realized at the population level if we are successful in preventing the child maltreatment from occurring and not just trying to intervene to reduce the negative outcomes for children and families. Thank you. I will stop sharing my slides and happy to open it up for discussion.
Terrific. Thank you so much, Tracie. Such good information, lots to dig into. So folks have been posting in the chat and the question and answer. So why don't I start with a few here, and then others can you continue to layer questions on here. So one of the, kind of going back to the beginning, Tracie, where you were talking a little bit about terminology. Some folks were confused about just sort of how these things fit together: ACEs, child maltreatment, child abuse and neglect. Can you say a little bit more about how we can kind of wrap our heads around sort of the meaning of everything in those spaces, given that those terms are used interchangeably, whether that is a good thing or not?
Yeah, so I feel like when we, I always like to start with language for that reason, because there's a lot of confusion of what the terms mean and whether or not they are interchangeably. For example, I find that people use child abuse and child maltreatment interchangeably. And so making that distinction that abuse is abuse, neglect is neglect, and together if you talk about them all together, then we would use child maltreatment. Now, when it comes to become more confusing are the terms adverse childhood experiences, ACEs, and childhood adversity. So what's really confusing about the ACEs is that they also include child maltreatment. And so I think what's important to understand is that that term ACEs versions of that was used before 1998, before the Folletti study, but it really became coined for those 10 experiences in 1998. And then that term itself isn't used consistently. So people will use the term ACEs, but it might include 5 of those ACEs or some of those ACEs from the original study and then different ACEs that weren't in the original study. So I think that's where the confusion really comes in and how we can use the term ACEs properly. I think when in doubt, I go to the term childhood adversity because I think it's the most forgiving and it's the broadest. So if you're trying to find a term that you think is the most inclusive, that's the one I would use. If it's just abuse, you can say abuse. If it's just neglect, you can say neglect. And if it's both child abuse and neglect, then you can say child maltreatment. But I agree, it's quite if you kind of go back in time, even the terms, we didn't even call it child abuse when we first started recognizing this as a medical concern in the first publications.
Okay, great. Sexual abuse, you were showing some statistics. It may have not just been around sexual abuse, but other things as well. And a couple of people kind of expressed surprise at the high prevalence that you were referring to. And I wonder if you could say a little bit more about just that, about the prevalence of sexual abuse in particular, and whether or not your research or others in the field have shown any kind of change in the trend around prevalences of different forms of abuse from the time, let's say, dating back to the 1970s when child abuse and neglect became a bigger public concern.
Yeah, so we don't have a lot of good data in Canada. You have much better data in the United States. You've been asking these questions for a longer time and in a variety of large scale surveys. So in Canada, though, we don't have longitudinal data where we can really understand changes and trends, but we do have some cohort studies where we can look at cohort effects and are able to look at trends over time. So from an age cohort effect, it does look like in Canada that child sexual abuse is declining, and I believe that data from David Finkelhor in the United States shows that there's declines in child sexual abuse as well. Now, the difference in the prevalence from study to study or country to country can often be based on how we define sexual abuse and what tools and indicators we're using to measure that. So some of it could be a variation in measurement. Some of it can be a difference in how we define it. So what we consider sexual abuse in terms of a definition or a clinical perspective also has changed over time, and that can be reflected in a prevalence study. But interestingly, there's new data from Australia. So from Ben Matthews, I highly recommend looking at his work that has recently been published in the last maybe year or 2 years. He has done a wide national survey. So he has probably at least 10 publications from that now. One of them is a prevalence. One paper focuses on prevalence. And the prevalence of sexual abuse in Australia is actually much higher than any of the numbers that I presented today. And I had the same question for him. Is this surprising to you when you got that number? He believes that it is, the tools that he used were validated tools developed with David Finkelhor from the United States and similar to other studies that came out of the UK. What we're doing in Canada in the spring is we're actually using his tool along with other tools that have been used in the States and in Canada. And we're actually going to collect data using the different tools and then compare whether or not our prevalence is different based on the tools that we're using. So we're really trying to, in our lab, make efforts to improve measurement in the field, because some of these tools that we've used, especially for ACEs, which were never developed using psychometrics, in other child maltreatment prevalence tools are more well developed than the ACEs tools, but a lot of these tools are 20, 30 years old, and we haven't updated a lot of them. So we're trying to do some work in that area to kind of better understand precision of measurement.
That's fantastic. I'm glad that that's happening. So that's in the spring. You said that's coming up.
Yeah, so it's submitted to ethics right now. We're hoping to collect the data in spring, and it'll be a national survey across all provinces. Unfortunately, not territories in Canada, but across all the 10 provinces.
So getting into the research now on protective factors a little bit, you mentioned a number, and so I want to kind of focus on a few. You talked a little bit about internal locus of control, which is familiar to some of us in the field, but probably less familiar to people who are, not doing research in this area. Could you say a bit more about what internal locus of control is and how it relates to the way we think about resilience? In other words, how does it contribute to somebody doing better than expected based on, whatever measure we're using as an outcome?
Yeah. So I think a part of, one thing I'll say first is what we were really tried to focus on in our research are things that are modifiable, things that we can change. There's some things that we, we can't change. Like, for example, if you look at the construct of sex, sometimes you'll hear girls are more resilient than boys. And, that may very well be true in terms of data, but it doesn't really help in terms of individual level protective factors. So we wanted to focus on things that perhaps theoretically in an intervention you could develop within an individual. And so this idea of internal locus of control is that you can imagine a child growing up in a household where they're experiencing abuse and neglect, and that they feel helpless, perhaps, and that they feel that that they have no ability to change their situation, that this is the situation that they're in. They're, a child who's being abused by an adult, and there's no way to escape. And someone who, so they may not, with that, they might not be optimistic for the future. So these concepts kind of go together. So they might not think, about their future, or that they have any ability to make improvements in their life. So that's sort of someone who doesn't have a locus of control. So they just feel like they're a victim of their circumstances, and that they have, there's nothing that can be done to get out of the situation or improve the situation. Those individuals don't do as well, according to our research. So if someone believes that there are things that they can do to improve their situation, or to get out of an abusive family, to make plans for the future so that they have the ability to live independently from that experience and move beyond it, that they can make change in their life and they can improve their situation. Those are the individuals that do better. And from an intervention perspective, if someone's experienced child maltreatment, helping them to see that their whole life doesn't have to be defined by this, and giving them ways to make plans for the future and to have resources so that they can see the future and develop that and be in control and not just be a victim of a circumstance, then those are the individuals that tend to do better.
Okay. And so let's take that person who is goal-oriented and has that sense of control, and you put that person into a school context. There are a number of questions about schools and protective factors in the school environment. What can schools add to that kind of disposition in thinking about the ways that environments can begin to support the health and well-being of kids who've encountered challenges?
Yeah, so I think a lot of these concepts overlap. So you have locus of control, so trying to change your circumstances, which may then make you want to think to the future or to have future plans. So that might be, I want to get good grades and graduate grade 12. Maybe I want to go on to university. So having that, a lot of those things can be fostered and facilitated within the school environment as well. Of course, if it's related to future. The school can be, of course, as we know, a safe place for kids. And for some kids, it's their only safe place. So it's the only, if they're experiencing a lot of abuse within the home and they don't have, a supportive relationship within their family environment, it might be that teacher that provides them that level of support. So I think schools actually can provide, have the potential to provide a lot of opportunity for children who are experiencing maltreatment in a number of ways. It can just be, teachers can provide that supportive relationship, because we know that's across the work that we've looked at, not just our studies, but across all studies, a supportive relationship. It can be a teacher, it can be a coach, it can be, it's more likely protective if it's an adult. But so you have teachers who are caring about these children, who are making them feel valued. They're providing that supportive relationship. I think providing these kids with opportunities so that they feel engaged in school, they feel safe in school, helping them when they're having trouble with their coursework or their grades, and trying to make it clear that how important education is and how important it is to have that school environment as a positive environment. So, setting goals for the future, whether they're small goals for a class or for a term, or with the larger academic goals, but setting those goals and helping students facilitate and fulfill those goals. I think the longer we can keep kids in school, definitely the better for their outcomes. And having those interventions that happen at the school level, I think, not only in terms of relationships, but in order to make their futures better in terms of academic attainment, I think is really important.
If I recall, you said that some of your research, it actually may have been the article that I use in my class. I think we talked a little bit about, that you published in 2011, a review article. So if I recall, family factors stood out as being the most protective. If in fact you have a child who's in a harsh and abusive home environment and don't have the opportunities there to bond with a positive and influential adult, to what extent can a teacher or somebody outside of the school context compensate for what that child isn't getting?
Yeah, I think it's an excellent question. I think it's quite promising, and it could be a coach, it could be a teacher, it could be an adult, like an aunt who doesn't live in their home, or a grandparent. I think as long as they have, generally speaking, when you look across review articles from the earlier studies up until now, as long as they have at least one supportive relationship, that child will do better. So I think what's really important is for teachers to understand that, to get some of this information at the school level. I mean, and I know some schools are doing this already, and they, kind of have that fostering mentorship and sort of have these resilience programs within schools. But I think even just trying to get this information at the school level so that teachers are aware of the difference that they can make for individuals across time, and then again to sort of be watching for those children that may need more of that supportive relationship, especially if it's identified that they might not have those supportive relationships within the family environment.
Ashley Burke posted a question here that I think is kind of interesting about siblings, asking whether there are any studies of siblings from a similar family environment, let's say one in which abuse was present, but have done different, have followed different trajectories, let's say, later on. Do you know of any studies that have looked at siblings and the reactions to?
I can't recall specifically. I think there are a very small number of studies in that area, and I think that some of the more specific studies are in the behavioral genetics literature, where they look at twin dyads. And they try to separate the genes from the environment in some of those studies. I think it's challenging to do because I mean, it definitely occurs where one child is abused and the other one isn't. It's not an area of research that I know that there's a lot being done in, but there's also a lot of the confounding in that with the sibling being aware of or exposed to. So they're still experiencing trauma, even if they're not the child who's being physically or sexually abused. So I don't know the literature extremely well, but I have read some of the behavioral genetics studies that try to look at that from a twin perspective. So I would guide you in that direction. I do think the literature is quite small because it's a really hard sample to gain access to for research.
Okay. I want to talk a little bit about public health in a moment, but there are a few other questions that I think I'll throw at you that relate to schools and families. So what Thomas asks about any evaluation of quality services, whether is there evidence, for example, that services that families receive, whether it's connected to the child welfare system or outside of the system, actually do benefit kids and promote resilience?
Yeah, so unfortunately, excuse me, that is something that isn't documented very well, at least in Canada. So often we don't know, we may have the information of whether or not someone was connected to a service, especially in the child welfare system. What we often don't know is whether or not that service was beneficial. So that's sort of where the data needs to continue to understand, that they're connected to services and what was the outcome and what was the benefit of that. So in some cases, we don't even know when kids are connected to services in certain data sets. So it's an area of research that I think we really need to do a lot more work in. In Canada, we're trying to do that at the national level with our surveillance data. So we're trying to not only understand which families got connected to which services, but then to take it one step further as to understanding those outcomes. So in Canada, anyway, we don't know that yet. And we still don't even do a really good job of documenting what services people are being connected to. I think in the past, it was this thought that that's all you needed to do was connect them to the service, and that was the end of the road. So they've been connected to the service, so problem solved. But I think that's from a public health perspective. I think that's something that's we really do need to think about is not only we need to develop services, we need to make them available, but we also need to understand whether or not these services are creating the beneficial effect that we think or that we hope that they are producing. And if they're not, then we need to be making sure that we're not investing our resources in something that doesn't show to be effective.
Thinking again about schools, Stephanie poses an interesting question. I hadn't thought about this one. Is there any evidence that you're aware of to suggest that the school type matters with respect to protective influences, private, public, homeschooling, anything along those lines?
That's a great question. I don't know. I don't know. There is a study that we do in Manitoba that includes all schools. So it includes public and private schools and independent schools. But it doesn't include measures. It includes measures of bullying, but it doesn't include measures of child maltreatment. We've never investigated it at that level, but so I actually don't know the question to that, and would be, very curious.
Okay. Let's turn to, if you're willing, to kind of the big picture now. I'm thinking about public health policy and social policy more generally. I'll start with a question from my colleague here, Katie McGuire-Jack, who asks about any recommendations that you would have for policymakers who are folks who are focused on social welfare policies about preventing mental health and substance use problems in kids who've experienced child maltreatment. Any recommendations you would make there?
Yeah, so I mean, I think anytime we can identify and intervene as fast as we can, I think is very important. So identifying first, we need to identify those who are at the greatest risk for doing that. So so that could be you know, from a public health perspective, trying to really have people understand the experience and the consequences and signs to look for in children. So sometimes behavioral issues might just be misinterpreted as, you know, this is a naughty child and we're not understanding why the behavior is happening and what the experience of those children are. So I think you know, from a high level, we need to be aware. Even to me, even understanding the size and scope of child maltreatment in Canada, when I present the prevalence numbers, and maybe even here today, people are surprised that their numbers are as high as they are. And I think that in and of itself helps to recognize that this is a problem that happens in the places that we live. It's not a problem that happens in other places or in other countries. I also think that we need to make sure that we have services available in a timely fashion for individuals. So we need to create policies that increase access to care and you know, are able to for individuals to connect to evidence-based services in the places that they where they live. And from a public health policy, there are lots of things that some of the negative consequences that occur in families are resource-based, especially with neglect, but it can also be, you know, in terms of maltreatment as well. So thinking about providing resources for families, so whether that's income supplements or, you know, providing them some kind of supports, can actually prevent the abuse from happening in the first place, which can be beneficial. But once the abuse has occurred, it's as quickly as we can identify it and as quickly as we can get that person connected to evidence-based treatment if that child needs it, is the best thing that we can do. And like I said, so a lot of the work that we're doing from these population-based studies is to try to understand what can we do for children and families who have experienced maltreatment to reduce the negative impacts. So we're still, you know, we're getting through that first phase of it, identifying what we think are you know, modifiable protective factors, and then the next phase for us would be to develop those interventions and to actually implement them in research to see if they are showing improvements, because these can be programs that can be implemented, for example, within schools or for families or for parents to reduce the negative outcomes.
You talked a bit about surveillance, I know a number of people have written about the pros and cons of surveillance and the ways we need to be careful as we sort of push on a public health agenda, which I would endorse, and I'm sure you would do, you would as well. Okay, what are your thoughts about the potential downsides or dangers in surveilling populations, even if it's for good intent?
Yeah, so it's a really good question. I even think the word surveillance we should change it because it sounds invasive and that's not the intent, right? I think that it can have at least in Canada, and I believe as well in the United States from the work and the information that I've read, is that it can have it can contribute to stereotypes, and it can have exacerbate racial discrimination, for example. So you know, and that's what we have to be careful of, I think, when even if we're looking at survey data and it's not necessarily surveillance, we have to make sure that we're not contributing to stereotypes and that the work that we're doing isn't creating harm, and we're not sort of you know, profiling some individuals. So I know that that's a downside and a concern that we have in Canada when we're looking at surveillance or we're looking at specifically child maltreatment data. We don't want certain people in the population to experience worse outcomes because we have now created the stereotype that this person is more likely to experience these adverse experiences within the home. So I think that's something that, you know, we have to be really aware of. But I also believe that without collecting data that is comprehensive and complete over time, we really don't understand how the problem changes. So if we understand the size and scope of the problem 20 years ago, that may not be the same as we have now. And if we don't continue to collect data, we can't really answer the questions of things that are changing. And we also can't understand if we are implementing policies at a population level, are they being effective unless we're also looking at the outcomes that those policies and programs are targeting?
Thomas asks an interesting question about the cost of alcohol and tobacco products and access. I think that provides, you know, pointing to the fact that these things are much more expensive in Canada compared to the US, and wondering whether there is any evidence to suggest that differences in cost relate to consumption, which in turn we would expect anyway would have some effect on child abuse and neglect. Do you have any thoughts about that?
Yeah, it's a good question. I don't know. I don't have any data or that I know of that's looked at that. But I think, you know, you can look at that from different perspectives. If we're looking at it from a parenting perspective, so the cost and you know, if it's the parent that's consuming these substances, again, it's taking resources away. In Canada, they are quite expensive. They are, you know, unfortunately, they're also very accessible. You know, there's rules in place to limit their accessibility, but you know, when children want access to them, they can find ways to get access to cannabis and alcohol and to cigarettes as well. So in terms of accessibility, you know, I think that from a caregiver's perspective, you know, again, this goes back to resources for the family. And I believe that increasing prices and taxes and having, you know, I think the public health policies in place and trying to limit accessibility, limit where you can use the substances, having extra taxes, the public health messages that are on the packages of all the negative consequences. I do think across the board, those do have, you know, show the best evidence. But it's, you know, the issue is also that we're still continuing to introduce new products into the environment, and really it's vaping now that is a huge concern, and it's a huge concern for parents who may think it's a healthier version of smoking, but also it's very, very popular among young people, you know, and especially because it's of the accessories and the way the devices that you're buying it, it's, you know, and the flavors are very appealing to young people. So I think accessibility from both the child and the parent side is an important factor for reducing the use. And but I do think those public health policies can have benefit, but the reality is they're still accessible for those who want it.
So for an effective public health strategy that prioritizes universal programs and other things that you talked a bit about, you suggested that we need more information on community and societal level risk and protective factors. Can you say a little bit more about what that might look like and how you might even collect, or anybody collect, those data given the challenges inherent in measurement in those spaces?
Yeah, it's a really good question. So as I mentioned, when we did that review in 2011, there was almost no even community level factors. It was really focused mostly on the individual and the family. So school and community were not widely included. So since then, though, community level factors are more commonly included in research. And so we tried to think about ways to include it. So we wanted to think about it in terms of where you live, your community, thinking about it in terms of safety within the community, the people that you interact with. A lot of people may play sports within their community, or have, volunteer, feel like a sense of belonging in your neighborhood, those types of things. So community is can be beyond school, and also for some people, they don't go to school in the neighborhood or the community that they live in. So we were trying to get some of those aspects in terms of was feeling like you wanted to improve your community or be a part integrated into that. Was that something that was protective? So we tried to tap into some of those concepts, but there's far less research tools that have been developed, to tap into those constructs compared to what you would think of at the individual or family level, or even within schools. So I think it's an area that we still need to do a lot of thought on, and to what should be included. And it also changes over time. What a community looks like now is different than what it did in the past. The societal level variables, I think, are the most challenging. And that's what I've struggled with the most, is how do you measure societal level factors? So you could measure them in terms of how you perceive society to function. And there are tools that measure sort of your perception of that, whether it's positive or negative or somewhere in between. But then there could also be systemic barriers that could be measured, and access to services are often included in societal level factors in terms of healthcare and other systemic barriers within systems of education and justice and that sort of thing. But to measure them as a protective factor at a societal level, I think we're still at the phase of really developing those ideas. So I'd be happy to have those conversations and to hear what other people think too, because I also think that it's different depending on where you live, but understanding that and then also turning that into the concept of a protective level factor. And then how do we, it's much, you can sort of run the play in your mind with, okay, let's try to improve self-esteem in individuals, or keep them in school longer because that is shown better outcomes. Those are more easy and concrete. I think once we get to the societal level, it becomes a little bit more either abstract or not explicitly tangible in how you do it. So I don't have those answers. Even in our recent data collections, like we would have sessions where we would sit with our team and other experts in the field and saying, how do we include this in survey research? And I think we're still, at least for us, at the early phases of that, and would be happy to hear what other people think.
Yeah, so if others have any thoughts about that, please type that into the chat or the Q&A. We're happy to take your thoughts on that. Heather asked a question about collecting data from specific communities and specifically names First Nation communities, but somebody else was asking about communities and thinking about rural and urban differences, and whether or not there's any evidence to suggest either that we see differences in child maltreatment rates across urban and rural contexts, and or how services might take hold differently in those settings.
Yeah, I mean, generally speaking, I think the answer to that question is yes, that we do see differences even at the provincial level in Canada, which would be the same as the level of the state in the United States. We see differences at the provincial level, where some provinces have more prevalence of child abuse and child maltreatment than other provinces or territories. Some of that is related to some provinces are more rural, have more rural areas or more city areas. I think that that resources are also very different in of course rural and urban settings. And in Canada, accessibility to services are much less when you live in rural areas. And you also sometimes have less access to other social supports as well. So I do think that it doesn't mean that, it's necessarily the same across the board, but, like every urban or every rural community will have similar trends. But I do, we also see it even in, we've looked at non-accidental injuries in urban versus rural hospitals in Manitoba, and we see differences in what kind of injuries that are coming up in terms of that are being presented at urban and rural hospitals. So I definitely think that you would see differences there, and even at the higher level across different states or different provinces.
I'm going to ask you one more question in the kind of the public health space, and then we'll finish with a question about the differences between effects of child abuse versus neglect. Somebody, Jamie, was asking about that earlier. So let's start. I have a question about, you talked about cross-sector collaborations. And again, that may be unfamiliar territory for some people on this webinar. Can you say a little bit more about what that really means, for people who aren't familiar with the public health model, and give a couple of examples of what that kind of collaboration might look like?
Yeah, so what comes to mind for me is I do a lot of work with the Public Health Agency of Canada, and I come to the table as an academic, as a researcher in the area, but I'm sitting at the table with people who are in child welfare, people who are in justice, people who are in come from education sectors and health sectors. So come from different sectors, and even I've also started something called what we call the Childhood Adversity and Resilience Research Training Platform, where we bring together community partners, students and academics to build research capacity and to facilitate research. So the idea, I believe that it's important to think about, is that you have people who care about the same things and are doing the same, the work, generally speaking, is in child maltreatment or in child welfare, but you're maybe doing your role is different, because for me, I'm an academic researcher. Another person might be a clinician who's a pediatrician who's seen children who've experienced maltreatment. You might be on the child welfare side of families who are being reported. It might be through justice. So we all have our own expertise and priorities, and we are interested in the same things, protecting children and families and improving those outcomes, but we are coming at it from different angles, and we're not talking to each other. And so we're trying to solve the same problem without understanding that this problem cuts across many sectors, and without sort of bringing everyone's voice to the table and sort of saying, well, this is the priority from my perspective, and this is priority from my perspective, and seeing how that comes together and how we can facilitate that. I think if we're not at the same table talking, then we make limited gains. And what I've learned the most is when I'm talking to other people who are working in child maltreatment or in child welfare who are not academics, and who are approaching it, whether they're a first responder or whatever the role is in the system of identifying and responding to child maltreatment. That's what I learn more when I'm talking to those individuals. And so it's very difficult to facilitate those conversations and to even find a time where you can all be at the same table at the same time. But I think that's when we make the most gains, is when we're bringing your expertise to the table, but learning from other people who also have the same goals and think about similar things all day long, but do it from a different perspective or from a different environment.
And even I think thinking back to some of the questions we were tackling in the early part of the Q&A, around terminology, I would imagine that also sort of gets worked out, right? That the people who are approaching these issues from different places have different ways of talking about this, similar ideas, and it's through that communication, right? That becomes you work through that level as well.
Yeah, and you can see when you talk to different people that they have their number one priorities might not be the same as yours, and then you might not have even realized, oh, that's a priority. But when you talk to other people, you realize, oh yeah, that needs to be done, or they have cautions about how to do things in a safe way, because it's possible that we never want to do harm, we never want to contribute to stereotypes or to have our work be used to the detriment of any individual or group. And if you're not sort of understanding child maltreatment, child welfare across sectors, you might miss some of those nuances. And so I think it's really good to listen to other people and to learn about all aspects of child maltreatment, not just the specific role you're playing.
Super helpful. Okay, so let's finish on that question that I mentioned a moment ago about any differences that you've seen in your own work or in others' research about how child abuse, and we realize that there are different forms of abuse, physical, emotional, sexual, relate to child neglect in terms of outcomes. Is there any evidence to suggest that neglect is worse, let's say, as a form of adversity and trauma?
Yeah, so there's that one study by Gilbert that was published in the Lancet several years ago now that I have cited in the slides, that does talk specifically about neglect. I think first and foremost that I think in the past people thought neglect was not as harmful, I guess, for individuals, and so I think that there's a lot of evidence that shows that it is equally harmful in terms of the negative outcomes for children. I think, though, what's also really important is that the concept of neglect often gets confounded and confused with poverty and resources. And I think that is something that we really could make great gains in from a societal level. So some of these children might meet the definition of neglect and be suffering the negative outcomes, but it might also be related to resources in a family. So it's not that we have to, so I think some children are suffering the consequences of neglect and maybe identified as having those experiences. But what we need to also distinguish between is that there are some kids who are emotionally or physically experiencing neglect, but it might be that sometimes it's a resource issue within a family. They have to work 2 jobs, so they get left alone for longer. They don't have enough food for the family, and so neglect is quite a diverse and complicated societal issue. It doesn't look the same, just like physical and sexual abuse isn't the same in every household. I think that's the same for neglect as well. Often it gets left off. It's one of the ones, like in Canada, we don't, the Canadian studies I showed you, neglect isn't in there. And if I had neglect in there, the prevalence rate would be much higher than the 32% that I presented. So we don't do a good job in Canada of measuring neglect at the national level. And we, as a researcher, we try to advocate to getting all of that included. Yeah, I think that it can be equally as harmful and equally complex to solve.
Understood. Well, I know we didn't get to everybody's questions. There are some still coming in the chat, and we'll try to capture those. Madison, maybe we can try to capture the chat. I can respond as best as I can, or pass them on to you, Tracie. But I really just want to thank you so much for taking the time to do this today. That the depth of knowledge that you bring to this and the wisdom that you bring to this conversation is just so helpful. And I appreciate and have admired your work for a long time. So I'm glad we finally got a chance to connect and have you talk about your research today. So thank you so much for doing that. And thank you, everybody, for joining us today. I hope that you enjoyed the conversation as well.
Thank you.